Hi, my name is David Keegan. I'm an academic family doctor here at the University of Calgary. Today we're talking about how to write clinical patient notes, the basics. So first of all, why write a note in the first place? Why are we writing notes when we see a patient? And it's really important to think about these purposes because that's going to help us understand why we do things in the way we do when we write them down. So one of the main reasons we write notes is so that we can actually document for ourselves what we did with the patient, what we discussed, and so on, so that later on we can go back and look at those notes and see what we did and what we heard from the patient. Great. They're also there to help other people do the same thing. One of our colleagues or another health professional or somebody else might have to be taking on the care of that patient, and they need to be able to see what we did as well. And there's also a documentation reason to do it for good medical, legal, quality reasons, so that we're tracking what we're doing, so that if there's any questions later on, then the answers are there, what we actually discussed, what we came up with, so that there's actually like a source of truth around these things. So there's a variety of reasons. And if you're a clinical learner, and you probably are if you're watching this video, there's another reason to do it, is so that you can display that you can think about a patient in a clear way, so that you can work with a patient, talk to a patient, examine the patient, and document things in a way that shows you have a clarity of thought and understanding about the patient and their issues. So with all that said, how do you actually write a patient note? Well, there's a few things you got to do. First, you've got to think about, is this the right patient record I'm looking at? So if you've seen a John Smith, are you looking at John Smith's paper chart or are you looking at John Smith's electronic chart? And it's amazing that in the era of electronics, how easy it is to be finding yourself in a different patient's clinical record, and you're happily typing away an obstetrical history on a 92-year-old man, and you just made a mistake. So be careful about that, and the very first thing you should do is check. Check to make sure you've got the right patient. Wow. So that's going to save you a ton of time, because if you ever do this incorrectly, it's a real hassle to fix all that. Next, if you're in a standard clinic, maybe it's a family medicine clinic or gastrointestinal GI clinic, and that clinic knows that they're the only things working there, you might not need a title. But if you're in the hospital or in a multidisciplinary outpatient setting where you share files and so on, you might actually have to put a bit of a title or a heading. So the heading would demonstrate or reveal who are you working with? What kind of service or what kind of group are you with? So it might be something like, the heading might be surgery progress note or something like that. And then that way it's really clear to everybody what your note is all about. Now, some other things to help with the quality and safety aspects are making sure you've got the date and time correct. So you've got the date. The time may not be necessary, but it often is, particularly in inpatient or particularly in emergency or ICU settings. The time is also going to be very important. And you want to make sure as well that your name, who you are, is clearly identified. So your name is going to have to be there at the bottom. Typically, we're going to sign and print your name and put your pager if you have one, and your designation. So if you're a second-year medical student, find out what your designation at your local school might be. But it could be something like, Med 2 or something like that, so that everybody knows what this note is about, when it was written and conducted, and then who wrote it. Was it a medical student? Was it a staff surgeon or somebody in between? So if you have all these things down, this is going to help with the safety of the note itself, to make sure that's a strong, clear note. Now then, the content of the note is something different. What goes on the insides there's 4 key categories for any note, and you'll see them come up over and over again. And they fall along a mnemonic called SOAP. S-O-A-M-P. And S is for subjective. So in all notes, you're going to be describing to some degree the story as you understand it. Often it's told by the patient or the patient's family themselves. And where possible, use their words. So if somebody says, I'm short of breath, don't write down, patient had dyspnea for 4 days. No, you don't say dyspnea. You actually say, patient describes being short of breath. times 5 days. By using the patient's words, it helps capture things better in a more nuanced way. And sometimes we might interpret a patient's words to mean a fancy medical word, but maybe we've got that wrong. So you almost never go wrong by quoting the patient's direct words. So in the subjective, you're going to be finding out from the patient and documenting from the patient stuff that relates to the story, why they're here today, or what's the issue now that you're picking up from. Next is your objective. Stuff in objective is what's objective, what you are seeing or finding out through objective means. So it's a combination of usually the glance. So you might glance at a patient and see how they're doing. So if it's somebody in an emergency room who's here with asthma, you might have glanced at them across the corridor, and if they're sitting up playing their mobile device, then you might write, five-year-old child sitting up playing a mobile device. Or maybe they're reading a book or whatever. Or maybe they're quite ill and they're gasping for breath and leaning forward and looking quite scared. Then you might say distressed-looking child, leaning forward, struggling to breathe. So those two descriptor glance sentences are very different. You'll also put an objective, things that you find. This is where your examination will go. And so the things that you find when you assess the patient, or you're looking at the bedside, you're looking at their heart rate, or you're checking their heart rate, listening to their lungs, all those sorts of things go under here. They're objective things that you are finding out. You're not relying upon somebody's story. No, stuff you're finding out. And then there's other objective things that will typically flow here as well. Labs or reports or whatever. You might have some other objective findings from tests will go here as well. The A stands for assessment. Assessment is what you think is going on, which is typically a diagnosis, but sometimes it's a differential diagnosis. And sometimes it might be an assessment of somebody's stability. Like if they're a long-term chronic type 2 diabetic, your assessment might be stable diabetes control, or unstable diabetes control needs more tighter control. Because everyone knows this patient's diabetic. There's no surprise about that. But the assessment today is their level of stability. So assessment can be a diagnosis or a differential diagnosis. If you have no understanding and you can't figure out what it might be, it could be like hypotension MYD, and you don't know why yet, and that's okay. MYD stands for not yet diagnosed. And if you think of a certain diagnosis, like let's say you think it's hepatitis, you put down query hepatitis, because you're not sure yet. You think it might be. And so there's different ways to make your assessment that it sort of varies by the patient. But it's basically your judgment of what's going on. And finally, P stands for plan. So this is what's happening now as a result of you seeing the patient or you being involved in the patient's care. So it could be things like things that the patient's going to do. So the patient might, you might have been talking to the patient and they're going to be increasing their high-intensity interval training as part of their exercise and going from 2 days a week to 5 days a week. You might have something like that. There might be some investigations you're going to do. And so the investigations might particularly help out with some areas of confusion that we already talked about under assessment. If you are going to give any therapies, they would go here. And therapies could be medicines or otherwise. Maybe you're giving them oxygen. Maybe you're going to be given a medication. And then if you're doing any consultations. So if you're going to be getting the patient engaged with anybody else. So like a dietitian, a surgeon, or whoever. So the content of the note is subjective, objective, assessment, and plan. And these are the main features of every single clinical note you're ever going to write. And to retrace, in order to make sure it's a good note, that is actually worthwhile, that hits all the issues of safety and quality and so on, check to make sure it's the correct patient that you're writing a note on. Make sure you've got some sort of heading if you're in a multidisciplinary or a hospital-based environment so that people know who is writing this note and what it's for. Make sure you have the date and time entered. If it's electronic, that will probably come up automatically. But if you're on a paper record, make sure you record that. And finally, make sure it's very clear who you are. So you print your name, you sign your name, and then you have some sort of designation so people know who you are. whether it's a PGY3, a med student, or whomever. So that's how to write patient notes, the basics. Thanks very much.